The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series. My name is Shannon McKernan, and today I'm interviewing Dr. Allison Lauren, an author on Fertility Preservation in Patients with Cancer, American Society of Clinical Oncology Clinical Practice Guideline Update. Thank you for being here today, Dr. Lauren.
It's my pleasure. Thank you for having me.
First, can you give us a general overview of what this guideline covers?
Sure, I'd be happy to. So as you probably know, ASCO first published evidence-based guidelines on fertility preservation back in 2006. And I guess happily for everyone in the field, there's been some evolution over time. And so periodically, as you know, ASCO likes to update guidelines, particularly when there are changes in the field or changes in evidence. And so we had a guideline update in 2013. And the purpose of the current guideline update is to provide some additional information to our providers about using hormonal methods to potentially preserve fertility or at least to reduce the likelihood of chemotherapy-induced ovarian insufficiency. So a lot of what prompted this guideline update was a signal from the literature that use of gonadotropin-releasing hormone agonists may change the way that the field is viewed.
What are the key recommendations of this guideline?
So several of the recommendations have not changed at all, but they bear some discussion because they're very important. So the key guidelines that have not changed are first to raise awareness among people who treat cancer that patients are interested in discussing fertility preservation. This is something that has been shown to be of great import, particularly to younger patients and to patients who are worried about their future fertility potential. And there's also evidence that shows that having the conversation, even if patients don't engage in a fertility preservation method, can reduce distress and regret and improve quality of life after cancer treatment, even just from having the discussion. So we want to raise awareness of the issue and make sure that providers are talking to patients about this. We strongly urge that providers refer patients who are interested in fertility preservation and even those who may not be sure to see a reproductive specialist. And we want to raise this issue so that people remember to address this as early in the treatment planning phase as possible. Another aspect of the guideline that really hasn't changed are recommendations for adult men, where we strongly urge sperm cryopreservation as the most sort of time-honored and proven technique to preserve fertility in men. There are other options such as testicular tissue cryopreservation, which are still experimental. And then for adult women, this is probably where the field has evolved. Some things that have not changed are, again, ASCO's recommendation that embryo or oocyte cryopreservation are both options for postpubertal women, and that both of these are viable options for preserving fertility. There are some surgical techniques that also can be employed, including ophoropexy, which is the process of moving ovaries outside of the radiation field, and considering more conservative surgeries for women who have gynecologic cancers. So, and then the other aspects of the guideline are to discuss in a little bit more detail the roles of ovarian suppression and ovarian tissue cryopreservation. And then finally to encourage all healthcare providers to be educated well enough to discuss the risk of infertility with cancer-related treatments, to encourage everyone to participate in clinical trials when they're available, and again, to be sure to provide both psychosocial and gynecologic support for patients, women, as well as men, to work through these risks and decide what's best for them. There's also another aspect of the guideline addressing children, for children who are undergoing cancer therapies, who are prepubertal. Fertility preservation options are limited, unfortunately. and gonadal tissue cryopreservation are really the only options at this point, and they're both investigational.
And what prompted the update to recommendations 3.5 and 3.6?
So as you know, ASCO wants to stay current with the field. And in the last 4 or 5 years, there have been a number of publications that have evaluated the role of GnRH agonists or antagonists in preserving ovarian function. And the data has suggested that there may be a signal. And so we wanted to be able to address this more fully. So there were a number of randomized trials as well as several systematic reviews, all published basically in the last 4 or 5 years, that have suggested that GnRHA may have a role in preserving ovarian function. And in some studies, the number of pregnancies that were reported were actually increased in the patients who were treated with GnRH agonists. These are primarily in young women with breast cancer. That was the group that has been most well studied and was shown to have a benefit or a potential benefit from GnRHA. And so we wanted to make sure that we discussed that more specifically. This has been an area of great controversy for many years. And although the data is not perfect and still remains controversial in some ways, ASCO wanted to acknowledge that it appears that in young women with breast cancer, GnRHA may reduce the likelihood of chemotherapy-induced ovarian insufficiency. And so in situations where more traditional methods such as embryo or oocyte cryopreservation or even ovarian tissue cryopreservation are not feasible, either for financial reasons, logistical reasons, medical reasons, that there is this other option that's available that has been studied and may have some effect. So that's recommendation 3.5. Recommendation 3.6 addresses the issue of ovarian tissue cryopreservation. So this is a technique where pieces of ovarian cortex that contain the eggs are surgically removed and frozen and then can be reimplanted at a later date. And as I mentioned earlier, this is the only method that would be available for girls who have not gone through puberty and is also a viable method in women as well. And some advantages of this technique are that it does not require any waiting period. So women who are undergoing oocyte harvest for either oocyte or embryo cryopreservation need to go through some hormonal stimulations. And so there may be a delay of 10 to 14 days before the eggs can be collected. An advantage of ovarian tissue cryopreservation is that the tissue can be frozen immediately and therapy can be started urgently or emergently. Some disadvantages are that we don't know whether this approach is safe in patients with hematologic malignancies. And so there's a lot of a study that still needs to be done in certain populations. But this is an emerging technique that we think has promise for the future. And so we wanted to be sure to address that as well. That was recommendation 3.6.
And finally, how will these guideline recommendations affect patients?
Well, we're hopeful that these guidelines will, first of all, remind all providers, and we really want to encourage that we want to be inclusive when we refer to providers. So physicians, advanced practice providers, even social workers, urologists, hematologists, gynecologists, anyone who is taking care of a patient with cancer should be aware of the potential risks to fertility that occur when patients receive chemotherapy or radiation therapy. And so we want to make sure that these issues are discussed with patients. And so our hope mostly is that patients' awareness is raised either through the guidelines themselves or through discussions with their providers so that we can better address this very emotionally difficult challenge. Patients are often described as, young patients with cancer are often described as undergoing a sort of a double threat where they first have a cancer diagnosis that is, of course, jeopardizing their lives and certainly their current way of life. And then on top of that, to also have a risk of fertility is an overwhelming and very scary proposition for many of our patients. So we really hope that by updating the guidelines and raising their profile in everybody's consciousness, that the discussions will happen more frequently, that providers will feel more comfortable discussing to some degree what the options are for patients so that they know how to think about it. We're hopeful that these kinds of guidelines will encourage cross-collaboration between the oncology community and the reproductive endocrinology community, such that our colleagues in gynecology will understand that these patients need, fairly urgent attention and expedited appointments. And so we're hopeful that institutionally, locally, mechanisms to expedite referrals will be built into place at institutions that don't already have these. And we're also hopeful that in the long run, more patients who are interested in fertility preservation will be able to engage in that practice and preserve their options for the future. And that over time, even just having these conversations and educating the patients about these issues will ultimately reduce their distress and provide a better long-term quality of life, whatever they choose about preserving their own fertility options. Just two more things that I wanted to mention. One is that we think that there's a role for our colleagues in reproductive endocrinology and urology to help with patients even after therapy is completed. So patients who may not have engaged in a fertility preservation method before treatment may benefit from referrals to fertility specialists even after their therapy is complete. And an additional point is, which is key, is that men who are exposed to chemotherapy are strongly recommended to use some form of birth control or contraception, because the sperm counts and the quality of the sperm once exposed to chemotherapy can be quite compromised. And so we feel strongly that patients should be protected by using contraception after exposure to chemotherapy.
Great. Thank you for your insights on this guideline, and thank you for your time today, Dr. Lauren.
Oh, it's my pleasure. Thank you for giving us the opportunity to share this information with our patients. We really hope that they benefit from it. That's really ultimately the goal. Thank you so much.
And thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. If you've enjoyed what you've heard today, please rate and review the podcast and refer the show to a colleague.